So, as I had mentioned earlier, I'm going to be starting a 10 episode, a small mini series where I am going to be doing interviews with our community heroes. And like we talked before, heroes, who are our heroes? Uh, like I said, I read somewhere that superheroes don't always wear capes, some wear scrubs. And in this current situation of a worldwide pandemic of coronavirus, our doctors, our nurses, our frontliners are truly heroes. So, I will be interviewing some of the physicians and nurses who are working in the front lines. I am a primary care physician myself, but I am behind the lines at this point, and I have so many questions for them. We want to hear from them, we want to see how they are doing, how they are going through while taking care of such sick patients and putting themselves at risk, their families at risk, going through this situation. So, today we have in our studio Dr. Shams Iqbal. Dr. Shams Iqbal is an interventional radiologist at MGH Boston. He is the Associate Chief of Division of International Radiology and has appointment at the Harvard Medical School. He is expert in guided therapy with special interest in developing new treatments for cancer like liver cancer and kidney cancers. He is expert of imaging and imaging guided novel treatments. He is well published and has spoken around the world. His latest focus is on minimal invasive treatment of prostate enlargement. So I'm going to be talking to him.
Yeah. So, first of all, I have a few questions about you guys. You are frontline. So, you are interventional radiologist at MGH. How long have you been there?
I trained there, and then
Hmm.
I worked for a little bit in Lehi Hospital, which is a part of Tufts, and the
Yeah.
cross. And then a couple of years ago, I went back. So I've been doing this since almost 10 years. So yeah.
Okay. Okay. And so, right now, what's going on out there in the hospitals? Have you been redeployed to go in as a hospitalist or in the ICU?
Yeah, so it's a very different environment. So right off the bat, when initially, as we know, America was lagging a little behind, but when we started taking it very seriously,
Hmm.
we right away went to the drawing board and figuring out how best we can manage this. Once it was designated a epidemic, and then
Yeah.
after a couple of weeks later, it became a pandemic. So we knew that it's coming. So
Hmm.
we started, and also, like, as you know, this is a very new disease. We don't know much about it. We are learning on the go, as you know, like learning on the job.
Right.
So
Right.
every time we learn about it, we try to change. Everything is very fluid, very dynamic. So initially we thought that we didn't know what was going on, because, as you know, probably from the news, China did not give us much information, much heads up.
Mm-hmm.
We started
Mm-hmm.
learning the bad part from Italy, and after that, so we felt that, it's mostly like pulmonary and intensive care based, and and then suddenly you must have heard the personal protection equipment, then PAPR, and then the
Mm-hmm.
sudden shortage for ventilators. So a
Right.
lot
Right.
went on in a very short period of time. So eventually we went to the drawing board. We did a lot of planning along with the leadership, and we are at a stage where we are like, in MGH we have almost 450 ventilator beds set up. It's
Okay,
amazing.
that's so cool, to be in
Yeah.
a place like that, one of the best places on earth to be working and to be sick. If you're sick, if you're there, you have better chances of getting protection. So you
Mhm.
have created additional beds. How much did you have before in the ICU
So,
beds?
so on a standard basis, MGH has 110 intensive care beds, ICU beds.
Mm-hmm.
But
Mm-hmm.
because of this, we have devised all the bunch of ORs for this, and all the surgical processing unit, and pre-surgical, post-surgical centers. And we have taken a lot of areas, and we have all designated them as intensive care unit. And we have devised in a way that all the people who are usually involved in this, including the anesthesiologist, the critical
Mm-hmm.
care, the pulmonary people, the ER people, they are all in the front line. And and the secondary people who are like less paraclinical and less clinical, they
Mm-hmm.
have started managing the floors. So there have
Mm-hmm.
been a shift. It's a stage where it's kind of all hands on deck. So,
That's true.
as you probably know, my background is from radiology, and I do interventional radiology, which is image
Yeah.
guided surgeries.
Mm-hmm.
So, barring us, most of the imaging people, they don't see clinical patients. So what happened, like 3 weeks ago, the authorities came to us and asked for help. So we initially gave our residents, then we gave them our fellows, then all the APPs, which are the PAs and the physician
Mm-hmm.
assistant and nurse practitioners. And
Mm.
last week we gave our like junior staff. The reason why we gave junior, because we wanted, we were looking, the criteria for looking was how close are you from internship, because
Mm.
people who are like 20 years out, they might not remember much, and people who are
Yeah.
like 5 years out, they have still some sense of how to manage a clinical floor. So
Mm.
it's a strange world. It's an unprecedented world. We don't have much to learn from.
Yeah.
The if you want anything comparable, you have to go all the way back to 1920, 100 years ago,
Mm.
before you can
Yeah.
figure out like something of this magnanimity hit the Mother Earth.
Right, right. And so unprepared for it, right? So that must have
Yeah.
been really, it's like a war and you are going in without weapons and without protection. So how's that now? You guys have enough equipment, masks and gowns and everything?
Yeah, we do like in reality, yes, we do. And in addition to that, first of all, like we are lucky that we have garnered a lot of personal protective equipments. In addition to that, last week there's a company known as Battelle. You might have seen in the news. They have devised a sterilization unit for N95 masks and other protective masks. They can
Right.
sterilize 80,000 units in a day. And they
Mm.
have like we could garner like MGH could garner one of the machines, because as you know it's a very high demand thing. So we could garner one of the machines, and it's like located in the assembly row area of Somerville. And
Mm.
all the partners institution, they are giving away their used PPE, and they are sterilizing and giving us back
So
in a
it
couple of
can
days.
be sterilized and used back.
Yes, yes.
It's
So
better than wiping it down and using it again. Like in the beginning, it seems like a lot of people had,
yeah,
the same, whole day they had to use the same one and stuff like that. So you
no,
guys have
it's
gone through harder
we
days.
still use the same one. We
Hmm.
recycle. So the way, if you look at the make of the N95 mask, so
Hmm.
it's basically, it looks like just a round mask, but it
Hmm.
has filtration layers in it, which is made up of four
Okay.
different kind of filtration. So
Hmm.
it might look like a simple thing, but it's not a simple straightforward thing. So what
Hmm.
we do, like first of all, you have to fit it. Like you cannot use just any of them, because for
Right.
me, like I'm a regular. If I use a
Hmm.
small mask, I will choke, and if I use a large mask, air will leak from the side nasolabial fold, which is like this area is known as the nasolabial
Yeah.
fold.
Yeah.
And air will leak, and then you lose the filtration. So it has some value like that you have to be measured, and then air is filtered through it.
Hmm.
So what happens is, like once we use, and we like I have been doing cases, procedures on COVID positive patients.
Hmm.
There's a certain way of donning and doffing it, because we are not supposed to wear the same thing in different rooms. So we go
Hmm.
in,
Hmm.
we line all the procedures for the COVID positive patients. We do all the procedures. We come out. We take it. We have already marked with name, and like the patient which I've been dealing is on sixth floor. So
Hmm.
I said Shams Iqbal, 6 East.
Hmm.
So within that mask is written. So then
Hmm.
there's a dumpster. I dump it there. From there, there's a system mechanism, chain mechanism by which it reaches the sterilization unit, and 2 days later I'll get back the same one. So I have two of them.
Hmm.
So
Hmm.
every day I cycle them. So
Right.
yeah,
Because as much as important it is to have beds and ventilators for patients, similarly important is to have, masks and protective equipment for you guys. So,
yes,
okay.
if you
So,
look at the numbers, we are the highest per capita patients of new COVID positive, because last I checked, we had almost 142 patients positive, physicians and
mm,
healthcare providers positive, and
mm,
290, almost 300 are still on the wait list, waiting. I mean, like they have been tested and
mm,
we're waiting for the
yeah.
results. Who knows?
Right. And that's that many less people, in the workforce. You guys are workforce, you're frontline, and that many
Yes.
people are out for like 2, 3 days till the test comes back either way. So so has there been any new development with the testing kits, like, more kits and a better one, which actually gives result right away?
Yes, we have made like huge improvements like in 2 weeks. If you go back 2 weeks ago, the standard testing was the CDC testing, which takes
Mm-hmm.
72 hours to return the results.
Mm.
Last Sunday, which is like 9 days before today, no, 12 days before today, we had a in-house testing which we can return in 6 hours.
Wow, that's pretty cool. So
That
when
was a
was it
big.
developed?
It was developed in MGH only, but the issue is like we have very few kits of those, so we are only giving it to people who are very sick and
Yeah.
quickly need to make a decision. For example, it's a very weird time. 2 days ago, I was on call, and as you know, like the sign symptom by which we start suspecting someone with COVID is
Mm.
shortness of breath,
Mm.
hypoxia, like
Right.
all pulmonary findings, cough. There was a patient who had massive PE, pulmonary embolism,
Mm.
and she came with the same finding, and she
Mm.
was also put into the same bucket. Then we got
Yeah.
a CAT scan, and we said, "Oh my God, no, she need a pulmonary thrombolysis." But I
Right.
did the procedure, I did the thrombolysis, but on the cover, we treated her as the COVID patient. But 6 hours
Mm.
later, when I was done, everything went over. We were expecting it, but the result
Mm.
came back as negative because we figured out
Mm.
like she's hypoxic because of the embolus, not because of the virus
Right.
disease.
Right. And that's the
So
tricky
we
part
have become
too.
so
Yeah.
unifocal. Like we have,
Yeah.
I'm sure we are probably missing quite a few things because we are so unifocal in thought process.
So how is it in the ICU? What is the outcome? Like we hear about the deaths and we are looking at the dark picture all the time, which is probably good, for public to have that. But also, are there patients who are recovering and then getting discharged? And what's that rate and how does that
Good,
be?
good that you asked because this morning we had a leadership meeting.
Hmm.
We have extubated 11 patients yesterday.
Oh my God,
Just
that's
yesterday,
amazing.
it was so positive. We all were ecstatic about it. Like, oh my God, finally! Because like the perception, if you look at the news, is like once you're intubated, it's pretty much a downhill turn. But no,
Yeah.
I've been extubating, and one of the patients was extubated after 14 days,
Oh my
and
God.
the patient is like probably, hopefully, going to be discharged tomorrow.
Hmm.
So
Okay. Okay.
there's a
That's
lot,
very
and
cool. Yeah.
till today. So MGH radiology, I cover like somewhat of the Newton Wellesley Hospital also, which is a part of subsidiary of Newton MGH.
Hmm.
Till yesterday in Newton Wellesley only, we had 78 patient and we had discharged 89 COVID positive patients. So the number
Oh.
of discharge increased for the first time yesterday than the positive sick patient we have.
Yeah. Okay, that's really good. And in terms of admission, has that decreased? Have we flattened the curve at all? Is the
Uh,
number less
so
or lesser than what you expected? I want to say
I I don't want to like speak before
ahead in time. Yeah.
ahead. Like I don't want to like outjump myself. I, I don't want to jump the gun because I feel we are making the turn. Because in the
Mm,
last 3 days we have like similar numbers each passing day, and that's
mm,
if you look at the epidemiology. Uh, every to keep increasing in terms of exponential curve, you need to have
mm,
a 1.2 times the number of cases the previous day. For example, if you have a 100 case today, tomorrow you
mm,
should have 118 case, which
mm,
is about 1.2, like it's
mm.
1.818 to be accurate.
Right.
And
Mm,
then the day following it should be 136. So
mm,
zero point 0.2 times of the number every day. So
mm,
it
mm.
keeps on increasing in exponential curve. So
Right.
the last week we have similar somewhat flattening of the things, but again the problem is like we don't know whether it's like initially when the curve was surging, was it because of new diagnosis or new infectivity, or
Mm,
probably it could be the infectivity is going on, we are not diagnosing more. So there's so
mm.
many unknowns, it's hard to tell. But yes,
Right.
in general, I believe we get a feeling with all the leadership meeting,
Mm.
we probably are making a turn.
Okay. Okay. And at this point in time, do you have empty beds where if somebody gets admitted or they have to wait or how's the scenario?
It's in the main campus. We don't have beds. We
Mm,
do have ventilators, as I said, and those
mm,
ventilators are like makeshift, as I mentioned
mm,
earlier. That like we on a standard bed basis, we had 110 ventilators, but we
mm,
reached the limit to 440 something.
mm,
So those beds they can be made if the patient.
mm.
So right now we had
Okay.
190 intubated patients in MGH. So we
Okay.
still have margin for
So the
intubation.
rest of the ventilators are still available.
Yes, so we still have
Mm,
margin. The
okay.
issue is like we don't have space.
Mm,
If that's why it's like more of a game. Like eh,
mm,
so there are three criteria of patient. One, who are coming with a suspicion of COVID. The
mm,
second, a COVID patient who are like different spectrum of disease severity, and
mm.
then those who are getting better.
Right.
How do you how do you allot the area
Mm.
space is them, because we
Mm.
don't want to intermingle them. So
Right.
if you increase the area where you have ventilator support, you eat up the area where you can
Mm.
see new patients or you can keep stable patients. So
Mm.
that's the jumbling, the domino effect which we our leadership has been working, and they're doing a great job. They're working 24/7. It's a lot of
Mm.
hard work to manage, and it's a very fluid and dynamic environment, as I said. But
Yeah.
yes, in MGH we can manage some more cushion, but in the peripheral hospital like North Shore, like
Mm.
Newton Wellesley, we are overwhelmed because just yesterday North Shore gave us a SOS call, so we had to
Mm.
send at least four intensivists and at
Mm.
least 20 nurses and other people to help them out because they were like
Oh my
overburdened
God.
with patients.
Oh my God. And
Yeah.
where did these extra ventilators come from?
Some of them we bought right away from the company. Some
Mm.
of them we got from the OR. So mind it,
Okay.
like every OR is inbuilt with a ventilator because you have
Mm-hmm.
very sick patient coming in.
Mm.
So we have transformed the OR to ventilator beds. So MGH has one of the biggest OR setup in the world. We have 110 ORs.
Oh wow.
So if you like, we are working at like 30% or 35%. So
Mm.
almost 60 ORs they have given up their machines for
Mm.
this COVID thing. And then the pre-surgery and post-surgical, they had a bunch of like so for 110 ORs you need to have 100 200 150 bed at least
Mm.
for pre-op and post-op. Pre-op
Mm.
don't need ventilator, but post-op people do need ventilators. So they had a lot of ventilators, and then
Mm.
you garner 10 here, 10, 20 there. So overall, like we could, it was like we pulled every possible strings, and we could reach to
Yeah.
that 440 point.
That's true. Whatever in the, it's like pull every weapon in your arsenal,
That
whatever, everything. Yeah, it's
we
literally
actually
that.
feel proud that like we are a part of such a great institution that they can
Yeah, so
muster.
that's very important, that's, top down management and leadership. If they take, adequate, they make decisions, and that's all right. So a few more questions, and then I'll let you go. So in terms of medications, we know other than ventilator support, and, maybe even I'm hearing about kidney getting affected, and so dialysis support. Is there a medication, like there is talk about hydroxychloroquine and, azithromycin, and have you done that? And is that there is some data right now?
There's no data because we are
Never been
testing. We are
used
testing at
before.
least there.
Yeah.
Last I checked, there were six trials going on.
Mm.
Uh, Ropinavir was one of the medication which Japan had a publication which said it works, so we created a protocol for that.
Mm.
Hydroxychloroquine is already there in at least two or three combinations. So we have
Mm.
six trials going on. But as you know, this is too early. Trials take years. Even though
Mm.
we are working on war footing, it will be like at least weeks before we come up with some information that who's doing how. Because so far we are getting information, and those are all anecdotal information.
Mm.
Anecdotal, like I don't know how much we can rely on there, but we are
Yeah.
working. In fact, like just this morning, South Dakota has decided to do a statewide protocol for
Mm.
hydroxychloroquine for the entire state.
Okay.
That would be an interesting thing to look at and
Yeah.
see how it goes. Yeah, the entire state. They are very sparsely populated, so hopefully they will have very good control of this. But we'll
Mm.
see. Like
So in
it's
terms
hard.
of, so the state doing it, meaning prophylaxis, giving it for prevention or for treatment of,
Yes,
preventive?
yes.
Okay, that will be, yeah, very
That's what they
nice.
say, but
Yeah.
again, I did not go through the entire protocol.
Yeah. Okay.
Hopefully, like one of my infectious colleague will probably sit
Mm.
tonight and go over that.
Yeah.
Or
Yeah.
that's what is happening. Like anyone, somebody throws a new protocol, one of us has to,
Mhm.
like few of us have to sit the whole night and read, and then
Absolutely.
next morning you have to brief like what's there. Is there
Mm.
any really skin in the game? They are not.
That's
So pretty
true.
much.
That's true. And when people, like especially layman, is sitting at home and not knowing much about it, and they hear, country's leader or anybody else talking about something that is out there can be used, So, for example, I get a lot of calls from my patients now asking for hydroxychloroquine for prophylaxis, and it's like, if it's there and if it works, why can't we have it? And so it's a difficult thing to do, and you don't want to. People don't understand. You don't want to put a chemical in your system and have adverse
Yeah,
effects of it.
you're already
All right.
resistant.
Hmm.
The big issue, like what we are most scared of, is there's a thing known as cytokine surge.
Yep.
That's what is deadly. So that's why, like, most of the protocol, we are trying to inbuild some, like tocilizumab is one of those interleukin
Mm.
6 inhibitor. Like, so
Yeah.
it
Yeah.
is
And you are
interleukin 6.
using that? Have you used that in
We
some
have
very
been
much?
putting
Yeah.
in the protocol. So
Mm.
again, anecdotally, we have had some
Mm.
research, some success, and we are
Mm.
proning the patient. We're doing anything possible,
Right.
as you know,
Right.
everything goes, whatever
Right.
patient. So in fact, like every day, I am doing at least 2 or 3 patients with COVID intubated patients, and they're
Mm.
so sick that it's like scary. But that's how it is, you know. Like we're fighting the battle. We'll see. Time will tell who ends up on which side.
That's true. And you guys, again, it cannot be said enough. You guys are the heroes. And I read somewhere on Facebook, which stuck with me, that not all superheroes wear capes, some wear scrubs. And you're actually wearing the scrubs. So you
Yeah,
are
I
the
just
ideal,
came
you
work.
know.
Yeah, yeah,
Yeah. So you guys are, out there fighting for all of us,
mm,
while you're putting yourself at risk, because, if you go in to for, like, let's say somebody's diabetes, or even, like, sepsis and ARDS, you don't get affected. Like, there's no chance of you getting it. So that's a different being a doctor there and versus here, where
yeah.
you're putting yourself and your family at risk.
The virus load is a big concern in the community, and that's why we put a lot of emphasis on personal protection. Because
Mm.
for regular people, like, you know, if you get exposed, you have one exposure, and as you know, like, viral load is a big key. Like any organism load is a big key. Like how
Right,
much
right,
bacteria you get inoculated with is significantly, because it depends how big, how profound immune response you will generate.
right.
If somebody lives in that environment, like, you are getting exposed like time after time after time, because you live, like, you do 12-hour shifts, and
Mm.
then, like, after a couple of days, your immune system just gives way, and it's
Yeah,
hard. So we have seen,
yeah.
like, our colleagues get sick, and because
So do
especially
you
those.
guys have a protocol, 3 days on, 3 days or anything like that? Not yet,
Yes,
because it's
we,
just
we do.
not enough.
We have
Okay.
right now. We're trying to do like 12 on, 12 off, like 12 hours,
Mhm.
one shift on, one shift off.
Okay.
But again, like, as you know, like, we don't know what's the right. Sometimes it's better to do like 3 shift and then give 3 days off,
Yeah.
or like 5 shift and
Yeah.
5 days off. That kind of.
Yeah.
But we have the threshold for somebody to call off is very low. Anybody who has small sniffles should
Mm.
get a test. So just today we were discussing in one of our meetings, we were discussing about the protocol. There's a new addition on the COVID testing, which was very different, weird. So
Mm.
we have, like, anyone who has new fever, new sniffles, new
Right.
cough, anyone who's from Chelsea.
Oh, wow. Why?
Just
What's there in
just by virtue of your address, you will get tested. Just by virtue
Oh,
of your address, you
wow.
get tested. Because there's so many cases coming from Chelsea that because
Mm.
we do that epidemiology match charting,
Mm.
and
Mm.
Chelsea is the hub of
Okay.
coronavirus in Boston right now, and we are really
Oh,
concerned. We need to somehow find a way to control that, and
okay.
that's one of the ways but which we're trying.
Okay.
Yeah.
So last question, I guess, what's your message for everybody? Social distances is working, this isolation, and people should continue doing because this is their part in this pandemic.
So my message again will be the same, like, which I have been reiterating every time I talk to people. They're like, keep washing hands, keep safe distance, because this is an unknown enemy, and follow the rules of the leaders. And like, everybody has the best uh, wishes for you and best will for you. So nobody wants the economy to go dead. Nobody wants you to be like jobless, but it's the need. That's why we are doing it. And once things are getting under control, we will get back. So please follow the rules, because if we don't fight it this way, we don't know, from a healthcare standpoint, we don't know any other way to fight it. So please help us
Mm.
out. Keep social distancing, wash hands, and hopefully we'll come back soon.
All right. Thank you, Dr. Iqbal, for sitting down with us for this very meaningful talk. And hopefully, we'll connect again with you in better times and then talk about this.
Sure. Thank you. Thanks for having me. Appreciate
Take
it.
care. Stay safe.
Stay safe. Thank you. Bye.
Bye.